So there's a lot of different people here. What departments are represented? Radiology's here, I know. Some ICU is here, right? DCO, I heard. Any maternal child? Yes.
GI lab.
And GI lab, yeah, very good. Anybody else? Oh, there's Linda Parrott from the ED. Are you ready, Doug?
I'm ready.
Okay. You're fine. So, malignant hyperthermia traditionally has been an issue for just the OR. And we recently had a mock surveyor here that asked about what is our plan to care for a patient who has an MH crisis event post-operatively. And if some of you know that succinylcholine is one of the triggering agents, what happens when you give that drug in the ICU or the ED? Are those people trained? So the answer was no. So that's why you're all here, so that we can educate you about what malignant hyperthermia is and how to identify when a person is in an MH crisis and what to do. So welcome all the other departments. I know GI is here because they're going to start doing general cases up in GI. I don't know if all of you knew that, but that is going to happen. This is actually your malignant hyperthermia cart that will be for your area. So we have a cart in all of the OR areas, the main, the pavilion, and the CVOR, as well as GI and then OB, because we do C-sections in OB, so they are susceptible to this too. So let's get started a little bit just talking about what malignant hyperthermia or MH is. So we talked about the education in the past was mainly for the OR. We are going to do a simulation too today to try to help you really put it all together. So malignant hyperthermia is actually an inherited disorder of skeletal muscle that's triggered in those susceptible, either human or animal, in most instances by an inhalation agent, so some type of a gas and or succinylcholine. Those are the triggering agents. It results in hypermetabolism. So I've heard a lot of people talk about MH over the years, as I'm sure people who work in the OR have. And I had somebody tell me a few years ago that if they were to rename this malady today, it would be hypermetabolism. Because really the hyperthermia or the rise in temperature is a late sign. There are other things that happen earlier. So it's like they've run a marathon, but they're just laying there, right? The skeletal muscle gets damaged because of that overheating, and the hyperthermia just goes up and up and up. They told us, is anybody here from the PAV? They were saying the situation they had over there, the patient's temp got up to 106. Were you there? Yeah. So that definition is actually by MHAS, which is the Malignant Hyperthermia Association of the United States. So it's a big group that takes a look at all reports of malignant hyperthermia, and they keep track of numbers and things like that. So let's look at some history for MH. So in 1900, we knew that people were dying in surgery, and it was some type of a heat stroke. We didn't know why. Have any of you had surgery in here, or family member, and you heard anesthesia ask them, have you or any member of your family ever had a problem with a general anesthetic? The reason they ask that question is right here. They need to know that if someone in your family has had an issue, it could possibly have been MH. And people died. I mean, the mortality rate was above 20% prior to them getting dantrolene. We have that down to about 5% now. So it wasn't until 1960 that we even determined that there was a linkage to the anesthetic agent, that it was an inherited familial disease, and in 1971 is when they found out how to even test for it. So they go in and take a little piece of muscle and they augment it with caffeine and halothane, one of our inhalation agents, and if it triggers in that, then we know that that person has a susceptibility to MH. Doesn't mean they're going to have a crisis every time they have surgery, but potentially they could, right? So then it wasn't until 1979 that an antidote was created for it, and that's dantrolene. So we can give the patient IV dantrolene now and reverse the symptoms and avert a crisis. If we know a person has a family history of MH or they've had an issue in the past, we just won't even give them any gas or succinylcholine. We just do straight propofol, right, for the whole case. And one of the things that we kind of talked about a little bit yesterday is succinylcholine really the drug of choice in the ED and the ICU when we're intubating people? Is there something better we can use that doesn't trigger this and just one less thing to have to worry about, right? Sorry, I've had a bit of a cold. So it is male predominant, sorry guys. It is race independent, 1 in 50,000 to 100,000 anesthetics. So how many anesthetics do we give a year at North Kansas City Hospital? Anybody have a clue? We're almost 1,000 a month just in the main OR. So between the main pavilion, CV, GI, OB, all the departments, we're well over 100,000 anesthetics a year, well over that. I can tell you, I've been a nurse for 41 years, been in the OR 35, I've seen two cases. Rhonda, I know you've been around for a while, you've seen one. To anybody else in the OR ever seen MH? It's rare, it's really rare. And it's even more rare in the immediate post-op period, and then even more rare that it would be a triggered event in an ED or a GI. So I think we need to keep that in perspective. It's not like we want to scare you that this could just happen anytime. It's pretty rare. And most of the time today, patients know that they have a familial tendency, and they'll tell you that when they come in. They know more about this disease than we do, so you need to listen to them. If a patient tells us that their family history of MH or had an event in the past, we will go straight to propofol, and we will keep this cart right outside the door just in case. Okay? You guys have seen us do that. Kind of funny, 600 cases of MH are in the United States. So that helps put it in perspective too. There are some hot spots. Can't explain Wisconsin, Michigan, West Virginia, some familial tendency in that area. One of the CRNAs told me that they worked in one of those hot spots and said that she did see an increase. The mortality has decreased dramatically since that introduction of dantrolene, so from 21% down to 5 to 7% in the hospital. It's still fairly high in ambulatory surgery. I think that's probably because they don't have the resources that the hospital has. So what triggers this event? We know that it is the volatile anesthetics, halothane, enflurane, isoflurane, sevoflurane, desflurane. You see they're all anes, right? So that's what the gases are like. And so those are just names of anesthetic gases. GI, you're going to learn more about that coming up. And then depolarizing muscle relaxants like succinylcholine. And then stress and temperature. It is a lot like a heat stroke. As a matter of fact, it's almost exactly like a heat stroke. So they are susceptible to stress and temperature. Are our patients stressed before they go to surgery? Yeah, pretty much. Nervous. They're not hot. They're usually a little chilly back there, but yeah. So the early signs. So we know that there are early signs for malignant hyperthermia, and then there's late signs. The early signs are muscle stiffness or some rigidity of their muscles. Excuse me. There's a lot of reasons for muscular rigidity in patients that come to surgery. Our muscle relaxants can do that to them. They can get kind of jittery. Lathina, one of the CRNAs, told me yesterday that giving fentanyl rapidly can cause muscle rigidity. But I can tell you that the CRNA is looking for a specific rigidity, and that's of the masseter muscle or the chewing muscle of our jaw. And we're not talking just a little tight, we're talking they get really tight. So those who work in the OR, you see them checking that jaw as they're putting a patient to sleep. That's what they're looking for, looking to see if that's stiff or rigid. And then they're watching their monitors to see if there's an increase in end tidal CO2. So these people are tachypnic, they're breathing fast, their heart rate is fast, they're blowing out a lot of CO2, so their end tidal CO2 is going to go up. And I mean up into like 60. Normal is 20 to 30. So yeah, it gets quite a bit higher. So that masseter muscle, there's just not complete relaxation. So it stays rigid and stiff. And they see it generally right after succinyl choline. And you may think, really, it's just muscle rigidity in the jaw. But if you see at the bottom, 50% of the patients with that were prone to MH. So it's really something that they look for, and it's an early sign. Increased CO2, tachycardia, breathing fast, and rigidity of the jaw muscle. More frequent in children than adults, just another reason to make us nervous when we're doing kids, right? And so the later signs that are going to happen is acidosis by ABG, and that's one of the first things that we draw is an ABG and other labs as well. The hyperthermia is a late sign. As a matter of fact, if your patient starts getting hyperthermic, you're at the low end, okay? Things have already started happening. You'll see evidence of breakdown of that skeletal muscle, rhabdomyolysis, and they'll have a cola-colored urine, very dark urine. As the condition worsens, they'll experience widespread organ dysfunction, DIC, congestive heart failure, bowel ischemia, renal failure, and death. And it can happen pretty quickly. So that hypermetabolism is just a huge consumption of oxygen, producing CO2. They're acidotic. They have that breakdown of skeletal muscle and resultant elevation in body temperature. So that's why it happens. That's why the temp goes up, because they're in this really hypermetabolic state. So it does depend on the potency, the concentration, and the duration of the triggering agent. So how much you give, how long you give it, and how long it's been in their system. Temperature, age, and genetic variability can also impact that too. What else can it look like? What else does MH crisis look like? It can look like a thyroid storm. It can look like a neuroleptic malignant syndrome, which I don't know. You have to look that up to even know what it is. It's a weird kind of condition that actually exhibits a lot like this. It can just be iatrogenic, just overheating, just being outside today for too long, right? I hear it's really hot out there. Heat illness, pheochromocytoma, sepsis, right? That's one of the things you might think of. And actually, cocaine or ecstasy overdose can create that hypermetabolic state too. And they've actually given dantrolene in some of these events successfully. So what are you going to see on lab? You're going to see acidosis, like we said, negative base balance, hypercapnia as well as hypoxia. You're going to see a PCO2 of greater than 60, elevated calcium and potassium concentrations, and elevated CPK and transaminases. So you're going to expect to see that. So there's some different clinical presentations. So a fulminant MH, just a crisis, you're going to see the muscle rigidity, high fever, increased heart rate shortly after you induce anesthesia. So it's really connected with the anesthetic agents that we're giving. That's why we talk about it happening in the OR or immediate post-op period. It would be really rare to have a patient on the floor 12 hours after surgery and have a true MH crisis. It's more related to OR and immediate post-op. That masseter muscle rigidity that we talked about, the jaw muscle gets tight. It can be an early, late signs. Uncommon for it to be truly late onset of MH, but it generally begins shortly after anesthesia finish time, usually within the first hour. So what do you do? What do you do if this happens? First, you identify that you have an MH crisis. And the first group that you want to get involved is anesthesia, because they know how to treat these events. They're educated in it, they know how to look for it, and get help. You're going to need help. It's why we created a cart, so that you can have everything that you need right there. So call for help, get someone bringing you the things that you need. First thing they're going to want to bring is the MH cart. And these, like I said, are located in all the OR areas, will be in GI and OB. For ED, IC, anywhere else in the hospital, it called the stat team. So, is any stat team in here?
There was.
Okay. Educating some of the stat team so that they know what to do in the event. But the most important thing to do is get anesthesia on board. And we just had a CRNA walk in, so that's amazing. Thank you. And we will, the stat team will call down to the main and get our cart, and we'll just have to bring another cart from another area to the main. But that's one of the things we're going to have to do, is help them out and get that cart pushed out so they can get it. So DCOs, you may be having to go get that cart. So what's in the cart? So what we've done in the cart is we've designated 4 different people. So the first one is the circulating nurse, which is in the operating room, but it could be the primary care nurse, right? So in this drawer, you're going to have some filters that we can put on the anesthesia machine. This is called soda lime that goes on the anesthesia machine. This turns purple as CO2 enters it. And on an MH crisis, you can actually see that they're blowing off so much CO2, you can watch it change. Pretty crazy. Lab, you can draw labs. Basically things that person needs to do. That person will probably also take care of the flow sheet, which you have a copy of the flow sheet in your handout, as well as the order set that we created. The next drawer is Ryanodex. So this is Ryanodex. We actually have some that we can use in our simulation that you're actually going to get to mix up and inject, so you can see what that's like. So dantrolene historically has been very difficult to reconstitute. It doesn't want to mix up very well. So the first drugs that they came out with were really hard. Then they came out with an easier to mix dantrolene called Revanto. The Revanto was a lot easier to mix, and now the latest generation is Ryanodex. Very easy to mix, very small dosing. I have a stop sign in here because the old dosing used to be, 36 60 ml vials is what we had to carry. Now it's 5 ml. They've come a long way with dantrolene. So here's a dosing chart. I put a stop because for us, this is crazy. We used to have a drawer full of dantrolene. Now we just have a little container. So I put a little stop sign in there. There's a central line kit in there too, because they're going to want to start a central line on these patients. There's a medication drawer that has antiarrhythmics, because with a rapid heart rate, you're going to start seeing some arrhythmias that they're going to want to treat. Ventricular arrhythmias mainly. Then you're going to want to cool the patient down. So the bottom drawer has ice packs, Foley catheter. We can put cold water. We can irrigate through the catheter with cold water. Even a rectal tube that we can irrigate with. Cold IV solutions. I mean, we're really trying to cool these people down. So we separated into those 4. Circulator, Ryanodex, medication, and cooling. Okay, because those are the 4 things that we're going to do. You're going to initiate the MH order set, which we created, draw labs, including an ABG, and then we also want you to call the Malignant Hyperthermia Association of the United States. And there is a nice poster on the side with their number. It's also here on the top. And so you can call that 1-800 number and you can tell them the symptoms that the patient is experiencing, and they will tell you if you have a true MH crisis or if they think it's something differential. It's usually anesthesia that's going to be talking with them, or we're going to be telling anesthesia what they're saying. Okay? Does it sound kind of crazy to you? Like nothing else you've heard of before? It's one of those things that I don't know about the other people who work in the ER, but I had to hear it multiple times before I really understood what it was. And you know, it was like this mysterious thing that happens to patients when they have a general anesthetic. But if you understand that it's simply a hypermetabolic state, and it's an inherited trait that not everybody has, but we have to be aware of it and be aware of how to treat it because it's a true emergency. So they'll want you to continue, and the MHOS will tell you if you need to continue the Ryanodex at about 1 milligram per kilogram. The initial dose is 2.5 milligrams per kilogram, and they'll do it every 4 to 6 hours for 24 to 48 hours just to keep things at bay. Monitor for reoccurrence rate. The recurrence rate is 25%. So if someone has had a true MH crisis, I don't know of anybody that would try inhalation anesthetic again. They're just going to go straight to propofol, don't you think? Yeah. They can follow with electrolytes, ABG, all the other things, coagulation studies, the things that we're worried about. Monitor for any signs of that myoglobinuria, so check in the urine for rhabdo. So what is Ryanodex? It's a hydantoin derivative. It inhibits the calcium release. It reduces intracellular calcium, and it will not affect the cardiac or non-striated muscles. So if you if you give it because you aren't sure what you're dealing with, it's not going to hurt them. Okay? So don't be, like we shouldn't have done that. No, it won't hurt them. So these are just different ways that they identify when patients are MH susceptible. So they've come a long way. They're doing a lot of different testing for MH. It's not the mysterious thing that it used to be. They know a lot more about it. And that's why I say these people who have a family tendency and know that they have the tendency for it, they know more about it than we do, truly. Anybody in here MH susceptible or family history that you know? They use some molecular genetics. The reason why I really wanted to show you this slide is that they're doing different things in different places. So in England, they're using a sequencing technique. They can identify some genetic changes, mainly in the DNA. So they're finding out earlier when people have susceptibility. All right, we did that. So any questions or any comments about anything?
The only thing I would add
Yeah.
is that if I've had a patient whose brother was known to be MH positive, so we treated him, the patient that I had, as if he were too. So like a first degree relative thing. So if they know that it's in their family, we just completely just skip the whole elimination on sex all together and just go straight to.
So what she was saying, and Doug, did you hear that? If a patient tells you that even a sibling or a family member, blood relative has a problem, we skip all that other stuff. We just don't want to invite trouble. So we won't give them the sucks, we won't give them the inhalation agent. There's other things we can do. So then you might ask the question, why don't we do that for everybody? Well, it's a little cost prohibitive to do that. Propofol can be pricey, and it's not necessary for everybody. Any other questions? Okay. Well, what we want to do with the second half here is I need some volunteers that are willing to be part of my team here. I need, obviously, a circulator or a primary care nurse. Take this back over there. We're gonna hide the cart, so you have to go get it. So we're in an ICU scenario, so I need a primary nurse that's caring for Jose up here. Can I get someone to volunteer? Okay, thanks, Tina. Since we only have one anesthesia person in here, guess what? You're it.
All right.
Yeah. So I'm going to have Tina up here first. She'll call for people. I need someone to be stat team and someone to bring the cart. There's someone who's willing to be a stat team person.
I can do that. I will.
Okay, thank you. And then who would like to be the person to bring the cart? Cart, nice. I need a couple people to do that. Okay, come on up. All right, so we're going to let just the primary nurse be up here right now.
Just hit me.
So that's you. And I am going to mic a couple of people. Definitely going to mic Tina because she's quiet. You're quiet. My mother actually told me I was a shy little girl. Can you believe that?
I mean, yes, I believe it.
Kind of helps Doug out. Anybody else over here quiet? Or just somebody wear it so when you guys all respond together. I'll let you wear it since you're.
She's going to feel like I'm the best specialist.
All right. So this is Rob back here from Laerdal. He brought the mannequin. The simulator. I'm sorry, it's not a mannequin. So she's very expensive. It's
You can call it a dummy.
this is a $15,000 dummy. So thank you. Not so dumb after all, right? So Rob has the scenario up on the screen. They have it in their hands. So I'm going to read. Well, Tina, why don't you read the scenario?
Okay. Patient is post-motorcycle accident where he fell attempting to avoid another vehicle. After the fall, he was brought to ED by ambulance. His initial exam revealed an open left ankle fracture, in addition to multiple fractured ribs on his left side. No other injuries were noted except for multiple areas of a road rash. He was complaining of pain in his left ankle and left chest and was only mildly short of breath. His initial oxygen saturation was 98% on 2 liters nasal cannula. He was admitted to the ICU prior to being taken to the OR for an external fixation. Hemodynamic and neurological statuses were normal in the ED. Want me to go on?
Yeah. So Tina is the RN caring for the patient. She admits him to ICU and sends him to surgery. He returns to the ICU about 2 hours later, excuse me, with an external fixator in place. Yeah, it's not there, but his foot is elevated. He was extubated without incident, currently on 2 liters of O2. SpO2 is 98%. Foley catheter was placed in surgery. No problems. He has an IV running. Neurovascular checks are good. So about an hour after he arrives, he begins to complain of feeling warm and a general stiffness of his muscles. You assess him and find, and here's your vital signs, should be 120/70, a heart rate of 88. Temp is 38 degrees centigrade, which is what? 100.4, so a little bit. SpO2 of 95. You contact the surgeon who orders some lab work. The people who have it in front of them. Nothing crazy. So Tina, you're caring for Jose, and about 10 minutes later, he continues to complain of being short of breath, feeling generally uncomfortable. He tells you he feels stiff and achy. A recheck of his vital sign shows a BP of 100/70. Temp is now 38.3. Heart rate of 110 and SpO2 of 92%. You increase his O2 and continue to monitor. What's happened to your patient? What do you see that kind of stands out at you?
The rigid muscles. His heart rate.
And his temp's gone up a little.
Uh-huh.
Okay. So, 15 minutes later, you see another change. His blood pressure is now down to 98/72. His heart rate is 115. His respiratory rate is 20. His temp is now 39 degrees centigrade. His shortness of breath is worsening. He starts to cough. You hear him coughing? Patient is increasingly tachycardic and now hypercarbic. Temp is continuing to rise. Short of breath is worsening and SpO2 is decreasing. What do you think you should do? So you're an ICU nurse, and I know I'm taking you out of your element.
Yeah.
So if you need help as a primary care nurse, generally call the stat team.
Okay.
So,
Okay, so I'm calling the STAT team at 3200.
yeah. So stat team, come on over.
I got a phone call.
She may actually have to respond somewhere. Huh? Can somebody else pick up and be the stat team, please?
This one hers?
I think it.
It's all the same.
Oh, okay, good.
Can you get the hypothermia or? Yeah.
I was supposed to get that, but now I'm stat team.
I'll go.
Oh.
That's fine. So you're calling all kinds of help.
I'll go get
I'm the car kidder.
Oh, okay.
Yeah, stand by.
Who else do you want to call, Tina?
Probably anesthesia.
Yeah, phone a friend. Let's get her over here. And let's see, here's the urine.
Oh, nice.
It might be coughing.
It might
Yeah,
be.
it might be some coffee in there. Okay, so you're seeing some rhabdo, right? You're seeing the skeletal muscle. What's one of the first things you're going to want?
Well, his lab values, and then I'm gonna, so I mean, kind of confirm that, but we're gonna secure the airway.
Yeah.
He's already having a hard time breathing, he's increased oxygen consumption, and so we're gonna wanna secure his airway.
Yeah, probably want to intubate.
And are these gonna be long?
You will find, yes, it has a tab that you break at the bottom. So just to remind you guys, you're not going to find, is this lower just by me pulling it?
Not lower the whole.
You're not, yeah, you're not, we found it. You're not going to find intubation supplies on the MH
Oh, I
card.
was just gonna ask that.
Yeah.
What's DVT?
So you really
Crash
need
cart,
to get the crash card at the same time. Yeah.
How come they don't put those on there?
It's just an awful lot to have on there. And really, in the OR, they're generally intubated anyway, which is where most of this happens. Did I say that once? So, yeah, that is something to think about. You definitely want a crash cart. So you're going to secure the airway.
So crash cart's here, intubating him,
Yeah.
alright.
We're gonna call the hotline too.
Very good. Very good. So if I had my phone, which I've misplaced today, you can call me. So I'll pretend I'm the hotline. Okay? So, ring, 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 ring. Hello?
Yeah, hi, we have some symptoms, I'd like to get your double checking on it, if you don't mind.
Okay, sure.
We're gonna 15 minutes later, get ready to go.
When you finish, that's what I was.
Yeah, there's your vitals on the screen. Oh.
Okay.
O2 sats dropping. Pulse was going up.
Yeah, this one, we have our O2 sats at 89. The pulse is 120. Oh, okay.
Do you have a temp?
It says 102.4, is that what that?
Yeah.
Listen, title CO2 would be,
Because that means you've already innovated at that point.
even so, it can be between 60 and 100 with these.
Yeah. So how high is your end-tidal CO2?
Right now, it's only 36.
Oh, that's actually.
Yeah.
Normal is 20, is that right?
Between 35 and 45.
Yeah.
So,
Is normal.
yeah.
60 is the one we're scared of.
Well, yeah.
Yeah, elevated.
I don't do that part.
Yeah.
Is there any family history with this patient?
Not that we know of.
Not that you know of. Okay. Well, I'll tell you, it sounds like you have an MH crisis going on. I think I'd go right ahead with the dantrolene.
Start mixing this up and.
And you can actually mix that. So I kind of want you guys to see what it looks like.
EBay stuff.
Getting.
You can actually mix it and inject it. It's the company gives you little vials that are not the real product for simulation drills. So kind of brings us to a point. Dantrolene is a very expensive drug.
So there's
That little tiny vial is over $1,500. So yeah, very expensive drug.
So you do want me to mix this?
I do. 5 mLs of sterile water.
Now, would we go ahead and be
I need
putting
a
on
needle.
ice packs like
Yes,
simultaneously?
yeah, his temp is up, so there's some ice over there. People can be, there's actual ice. Oh, you got it already?
I have no
Awesome.
needle.
So it goes groin, axilla. Just be careful, Maya.
I see it, yeah.
Good on there. There you go. So ice. We're cooling the patient down. We're mixing dantrolene.
There's no needle.
Oh,
Oh,
yes, there is.
I got
Here's
one.
some.
I got one.
Neck, sure. And I want you, after you mix that, to turn and show everybody what that looks like. It's very bright orange colored. It's almost fluorescent. And like I say, used to be really hard to mix. Not so much anymore. Not so much anymore. It's pretty easy to mix. It looks almost like Tang. Yeah. It's bright orange. But think about that, you know, the old vials, you had to mix 60 mLs of sterile water. Now, it's only sterile water that you use to reconstitute this, never saline, okay? And you had to reconstitute it with 60 mLs. What does your sterile water come in? What size? 50 mLs, the biggest, not 60. Or even if you had 10, you have to. So we had to have 2 to 3 people doing nothing but mixing. It was hard to reconstitute. They were big 60 ml syringes. We were pushing all 60 mLs, and the next person is getting the next one ready. So that whole Ryanodex or dantrolene thing was a nightmare. You see what it is now. And he weighs about 180 pounds.
Okay.
So on the back of your dosing chart, that stop, it will tell you how much to give for 180 pounds.
4 mils.
4 mils. There you go. And you can actually connect it to your IV and push it right in. Because I've got it all situated right here. I just give it in this one over here. It shut off just because I don't want to make a mess. Okay, your patient's temperature is coming down, looking better. Vital signs are improving. You've given a dose of Ryanodex. That is so weird, him breathing like that.
I just made the glow.
Jose.
Did you say how many milligrams of the dantrolene are in that vial?
It's, yeah, total
250 milligrams.
250 milligrams,
So
so
about
2.5 milligrams per
So about
kilogram.
4 mils, is that what you used?
We used 4 mils, correct. Correct. And the dosing chart is on here. We actually blacked out all the halves because, like anesthesia said, seriously, if it calls for 4.75, I'm going to give 5, right? So we just blacked out all the others so that it's a little bit easier. Okay, you saved your patient. Great job, everybody. Thanks for your help. Didn't they do a good job? Yeah. So you have a flow sheet there too, a sample flow sheet. And if you follow along with the flow sheet, it pretty much tells you everything that you need to do. So let's just take a look at that and some comments about what they did well, what would be challenging. Thanks you guys so much.
Oh, sorry.
Put it in and then put more stuff on.
Oh, just run the fluid, yeah, yeah. So what all were they called the stat team, right? That's the first thing she did. Did they identify what they had going on pretty quickly? Yeah? They got the malignant hyperthermia cart. Just remember that you may need the crash cart as well if you're in those other areas rather than the OR. Anesthesia did a good job evaluating what was going on, making sure we could intubate the patient, hyperventilated. For us in the OR, we want to get rid of all of that gas. We want to get rid of all of that anesthetic agent. So those filters that we put on the anesthesia circuit will actually clean all of that out of the machine fairly quickly. I don't know how long it used to take.
Before, we always ran like 10 liters of oxygen or more for like at least 10 minutes with a brand new circuit. And I know now, just kind of interestingly, that someone had left the filters on and somebody didn't catch it, and they turned the gas up high for some other case, and you could not get any, even forcing, you know, that gas through the filter, none of it was getting to the patient. So they're really, they do a good job.
They're
The filters
effective.
do a great job.
Yeah, they work well.
Yeah, they
So
do
it can
great.
take up to 10 minutes, but when we put these filters on, it takes much less time than that. So we'll hyperventilate with 100% O2. We will go ahead and change the anesthesia circuit because there may be some
Oh, yeah.
trace gases in
Yeah,
there.
absolutely.
And the filters will clean it out of the machine. So much better. I mean, they didn't have that when I first started in the OR. So, and we cooled them. We got the ice bags. That was very good. Continued to monitor the patient. Gave dantrolene. Called the MHOS Association. Got their opinion. Gave the Ryanodex. And we didn't mention it, but I'm sure the medication nurse was waiting there to do whatever they needed to do for the arrhythmias. So, good job. Do you feel like you know more about MH than you did when you first came in here? Good, good. So I have a post test there. So what we'd like to do is just measure your knowledge post. Again, don't put your name on it. Please circle post at the top so I know that it's post. I did give you, with the handout, some early signs, late signs, just some information about MH. We're always happy to answer any questions that you have, and hopefully this will make you feel more comfortable in the event that you have anything like that happen. So thank you all very much for attending.